The good news is, as was alluded to, is that we are making progress toward these goals, and that's very encouraging. Next slide. Just to review with you again, to reiterate what Ronnie said, the MRSA objective is to reduce healthcare-associated invasive MRSA infections from a baseline, which was reported through our EIP system of 26.24 infections per 1,000 persons, to a target of 6.56 infections per 100,000 persons, which represents a 75% reduction. Next slide. If you'll recall, we had intermediate targets, a 2013 target of a 50% reduction in the incidence of healthcare-associated invasive MRSA infections. And this slide shows the progress to date through the EIP program that I mentioned. Again, the baseline was 26.24 per 100,000 persons, and the current through the calendar year 2009 was down to 22.72 infections per 100,000 persons, representing a 13.4% reduction over a relatively short period of time. So this is very encouraging and, in fact, suggests that we are on track here. Next slide. I will point out through this slide that there are different kinds of invasive MRSA infections that are associated with healthcare. This shows the different categories. In the gray part of the pie there that's labeled 27% is the proportion of all invasive MRSA infections that had their onset in the hospital. But you'll see there's a large piece of the pie, the 59% blue part, that are also healthcare associated but don't have their onset in a hospital. Rather, they have their onset out in the community somewhere. They may be related to what happens in a hospital or in another healthcare setting, but they have their onset outside. The biggest reductions have been seen in the hospital onset portion, and that's good, but I show this slide to highlight that we need to make progress as well in some of these other areas that are equally as important. And that's one of the reasons why we need ongoing research, both to inform better guidance, but also better implementation strategies in some of the non-hospital settings to help us continue to move towards this goal. Next slide. The CLABSI objective that has been mentioned before, we measure through the National Healthcare Safety Network, and we use a measure that's called the standardized infection ratio. The standardized infection ratio actually is a way of controlling for differences in risk of infection across various unit types, various hospital types, et cetera. And so this ratio actually controls for that, and it compares the observed HAI occurrence during whatever reporting period you're interested in with the predicted occurrence based upon the baseline period rate, so that our baseline is considered a 1.0 standardized infection ratio from that baseline period of 2006 to 2008, and any improvement would be represented in a reduction of that somewhere below 1.0. And our target ultimately is to achieve a standardized infection ratio of 0.25, which would represent and correspond to a 75% reduction. Next slide. Again, the intermediate 2013 target was a 50% reduction in CLABSI as measured through the standardized infection ratio. And you can see from that slide that compared to the baseline period of 2006 to 2008, the SIR, or standardized infection ratio, through calendar year 2009 was down to 0.82, which represents an 18% reduction from baseline. Again, suggests that we are well on our way and on track to meet these targets. Next slide. And finally, I might draw your attention to a recent publication through CDC's Morbidity and Mortality Weekly Reports journal of what we call our vital signs that was centered around progress for preventing CLABSI that went a little further back than even this 2006 to 2008 baseline. And what that showed is that when we've been tracking rates 2001, we've seen fully 58% fewer bloodstream infections occurring in hospital ICU patients with central lines in 2009 compared to 2001. We also, because we have detailed information on these infections, we observed that CLABSIs caused by some germs have decreased more than others. Again, that's important information to know so that we can look at some of these other germs and find out what additional measures can be taken to keep us on target to meet our goals. We also discovered that many of the CLABSIs occur in hospital wards outside of ICUs and other areas of the hospital that are non-intensive care units, but also even outside of the hospital in hemodialysis centers. And we need to continue to refine our prevention recommendations and strategies for implementation in these areas as well to continue our progress. But finally, I'd just like to sum up by saying we're making good progress. We need to continue to be vigilant,